In part 1 of this series, we started discussing syringe infusion pumps and how they are an important part of our clinical practice. However, there are some invisible elements of how they work that can have an impact on clinical performance that you may be unaware of. We discussed a few of the invisible nuances of their operation in the previous module. Specifically, 1. The general mechanisms by which syringe pumps operate. 2. The delay slack can cause when starting an infusion and the need to remove the slack by priming on the pump. And 3. The flow irregularities that may arise when using large syringes at slow flow rates and the influence of stiction on flow stability. In this module, we will be building on some of the previous concepts and discussing a couple other factors that can have an impact on delivery when using syringe infusion pumps. This module series is not intended to highlight anything currently being done incorrectly or practices needing to be changed. Rather, these modules are intended to bring knowledge and awareness of some topics we need to remain mindful of, so we know what to expect and how best to respond in certain situations. Please note, these topics may not be a concern for every clinical situation, but for slow flow rates and rate-critical medications, these topics are essential to be aware of. The first topic we will discuss is occlusion detection. However, before talking about occlusion detection, we must quickly discuss pressure. The pressure we are talking about in this module is the pressure within the IV tubing as detected by the pump. Please note that this is not the vascular pressure. Within the setup, the fluid is always under a degree of pressure as a result of the flow being constrained by the walls of the syringe and tubing. This pressure is more or less consistent unless something restricts the fluid flow, creating back pressure. There are soft occlusions, which restrict the flow but allow the fluid to continue flowing. An example is the slight compression or squeezing of the IV tubing. Pressure will rise, but as flow can continue, it will eventually plateau at the increased pressure level. There are also hard occlusions, which completely obstruct the flow of fluid. Examples of hard occlusions are kinked IV tubing and closed clamps or stopcocks. In these cases, pressure will consistently rise as more fluid is forced into the tubing with no outlet. In addition, the patient will not be receiving any fluid during this time. In this section, we are going to be talking about hard occlusions. The ability to set a pressure limit on the pump to alarm if an occlusion is detected is an important safety feature and helps to minimize interruptions to delivery. But it takes time for pressure to build when an occlusion is present, and an occlusion alarm only sounds once pressure has reached the limit set on the pump. The occlusion alarm is not instantaneous, and until the alarm sounds, limited or no flow is occurring. The time to occlusion detection, meaning when the alarm sounds, is dependent on a few factors. For demonstration, here we are delivering from a 3 milliliter syringe, and on the pump, we have set a pressure limit of 500 millimeters mercury, or about 10 psi. There is a hard occlusion in the line. The slower the programmed flow rate, the longer it will take the pump to alarm. Since fluid is accumulating in the line slowly, this means pressure is only building slowly. Furthermore, the larger the syringe we are delivering from, the longer it will take for the pump to alarm. This is due to compliance, which we will talk more about shortly. As we can observe here, at flow rates under 1 milliliter per hour, there can be significant amounts of time that pass before our occlusion alarm will sound. As a result, there may be delays on the order of many tens of minutes where our patient isn't receiving any fluid. This is especially true in cases using larger syringes, where even at flow rates above 1 milliliter per hour, there can be very significant delays. Here, we are looking at different sizes of syringes delivering at 1 milliliter per hour. The higher the pressure limit is programmed on the pump, the more time there is between the point when the occlusion occurs to when the alarm sounds. For larger syringes, even at a low pressure limit, there can be significant delays before the alarm sounds. Therefore, to minimize the delay and the resultant period of no delivery, It is recommended that you use the smallest syringe size that is practical for your specific clinical purpose. Also, significant attention should be given to optimizing the pressure limit setting on the pump. However, as touched upon in the previous module, there is a limitation to using 1 milliliter syringes in some pumps. The resolution of the pump's pressure sensor may be limited in its ability to confidently detect increases in pressure due to the small diameter of 1 milliliter syringes. This is an inherent physical limitation for some syringe pumps. When compared to the pressure within the line, the force translated through the narrow syringe plunger button to the pressure sensor can be much smaller. In these cases, the pump may not be able to detect occlusions with a high degree of confidence. If possible, try to use 3 milliliter syringes rather than 1 milliliter syringes. 3 milliliter syringes still have the benefits of a small syringe, such as good flow continuity, but also retain adequate occlusion detection performance. That said, in neonatal cases, a 1 milliliter syringe may be the only reasonable option. In these cases, you need to be extra vigilant about occlusions, as the pump may be limited in its ability to notify you of an occlusion. Another consideration is to take care when setting the occlusion pressure limit. You may be able to set the limit yourself, or your institution's medical engineering department may program the limit. Either way, it is good to understand how we choose an appropriate limit. The lower the limit, the faster the alarm will sound, but you do not want to set the limit so low as to cause false alarms. There typically is some level of pressure within the line, and small transitory pressure increases may occur over the course of the infusion, but are not the result of an occlusion. You do not want the occlusion alarm to sound in these situations and stop the pump, as these increases in pressure are transitory. Limits need to be selected that have been proven by experience in your institution with your particular pump and the specific fluids and flow rates being used. This process means balancing the efficacy of early occlusion detection with the probability of false alarms. Let's say a true occlusion alarm has sounded, the pump has stopped, and you have identified the source of the occlusion as being a kinked or inadvertently closed or clamped line. What is the best course of action at this point? We will answer this question, but first, we need to talk about compliance. Compliance is the susceptibility of a material to deform or change in volume when it experiences a force, such as pressure. Rigid materials such as glass have practically no compliance, while materials such as rubber have a high compliance. Plastic materials, such as syringes and IV tubing, may seem to be quite rigid, but they actually do expand and deform a bit when exposed to the forces and pressure of the syringe pump. Not by name, but we did talk about compliance a bit in the first module when discussing contributors to slack during startup, specifically the elastic nature of the plunger head, syringe, and tubing. Different makes and sizes of syringe and tubing can have different degrees of compliance. The compliance of syringes tends to have a much larger impact on delivery because of their much greater diameter when compared to IV tubing. You can see just how compliant syringes are by pressing on the rubber plunger head and noticing just how much it moves while applying an increasing force. With a hard occlusion, as back pressure builds within the IV setup, it pushes on the compliant plunger head, syringe walls, and tubing. In an effort to alleviate the pressure, the compliant components deform, expanding the internal volume. The extent of this expansion will depend on the material's compliance, with more compliant materials deforming to a greater extent. As the materials deform, the pressure will continue to rise until the flow is stopped. However, when the occlusion alarm sounds and the flow is stopped, the pressure remains at its current level and the compliant materials remain in their expanded state. Going back to our question, what is the best course of action following a hard occlusion alarm? It may be a natural reaction to clear the occlusion immediately following the alarm and restart the pump. However, if you were to suddenly clear the occlusion, the fluid that has built up in the syringe and tubing will be delivered to the patient as an unintended bolus as the compliant materials contract to their original state. This unintended post-occlusion bolus may be in the range of about 0.5 to 2.5 milliliters, depending on your setup, and can be a clinical concern for some patients. We have already acknowledged that the higher the pressure limit, the longer it takes for the pump to alarm following an occlusion. This also means that more fluid can build up behind an occlusion, resulting in a larger post-occlusion bolus. Furthermore, the more compliant the syringe or tubing, the longer the occlusion alarm delay, since the syringe and tubing expand more readily to help alleviate pressure increases. This expansion also means that more fluid can accumulate, resulting in a larger post-occlusion bolus. 60 milliliter syringes are a good example of compliance having the potential to significantly impact delivery. 60 milliliter syringes generally have a much higher level of compliance than other syringe sizes. Even compared with 30 milliliter syringes, 60 milliliter syringes may be 4 to 7 times as compliant. This makes 60 milliliter syringes particularly susceptible to the limitations of high compliance, such as longer startup delays, increased time to trigger an occlusion alarm, and larger post-occlusion boluses. Following an occlusion alarm, it is recommended that the caregiver release any of the stored fluid from the tubing setup above the occlusion to reduce the pressure and remove the fluid that can lead to a bolus. Some models of pumps back up after detecting a hard occlusion as a post-occlusion bolus reduction feature. For this feature, the pushing drive moves back very slightly, allowing the stored fluid to be suctioned back into the syringe, reducing the pressure and removing excess fluid in the tubing. Backing up is limited, though, and may not be entirely sufficient to mitigate a post-occlusion bolus in all situations. For delivery of intermittent or bolus infusions, such as most antibiotics, a small bolus may not matter, and clearing the occlusion and restarting flow should be fine. However, in situations where you are delivering a rate-critical medication with a short half-life, such as a cardiovascular drug, you probably do not want to unintentionally administer a sudden bolus. In these cases, to release the stored fluid, you could remove the syringe from the pump, freeing the plunger button and allowing the stored fluid to flow back into the syringe, or disconnect the line close to the patient, then unblock the occlusion to allow the stored fluid to exit the tubing into the external environment. Alternatively, if you are using tubing with an inline stopcock, vent, or access valve above the occlusion, you could use this port to release stored fluid from the tubing setup. This type of tubing is very useful in allowing the stored fluid to be removed from the line without having to remove the syringe from the pump or disconnect from the patient. However, please be aware that all these practices will reintroduce slack, so recognize that you will have to either remove slack again before restarting, or be aware that there may be a further delay before your patient will again start receiving the fluid. With regards to occlusions, here are some guidelines and recommendations for consideration in helping to mitigate some of the topics we just discussed. Over the course of an infusion, there are times when the syringe pump may be moved up or down, such as during patient transport. There are other situations when the patient is moved up or down, such as parents wanting to hold their child. When discussing changes in height within this section, keep in mind that height change can either be the result of the patient or pump moving. These type of height changes have important clinical implications for syringe pumps and their accurate delivery of medication. Please note that although the graphics within this module shows a pump that holds the syringe horizontally, the topics and resultant effects are the same for pumps that hold the syringe vertically. Moving the pump up will have the same height effect as moving the patient down, as this serves to move the setup in a direction where the pump is above the patient. Conversely, moving the pump down will have the same height effect as moving the patient up, serving to move the setup in a direction where the pump is below the patient. We measure the height of the patient with reference to their heart. Gravity affects the movement of fluids the same as it does solids. When flowing downwards from a height, fluid can flow more quickly, whether coming from a bucket, waterfall, or syringe pump. Therefore, when the setup is suddenly changed such that the syringe pump is positioned above the patient, there can be a temporary increase in the flow rate. For example, in certain infusion setups, a sudden increase of around 2 feet can result in an additional 1/4 to 1/2 milliliter of fluid being delivered in a relatively short period. You may ask yourself, how could delivery increase when the pump's motor is mechanically controlling the speed of delivery? Well, the increased fluid delivered is not coming from the pump, but rather occurring as a result of small changes in the volumes of the compliant IV tubing and syringe. The increased gravitational pull is encouraging fluid to leave the tubing faster, resulting in the pressure decreasing in the IV setup. With less pressure, the compliant IV tubing and syringe barrel are able to contract a bit, and the plunger is able to decompress, thereby reducing the setup's internal volume. A majority of this change in volume comes from decompression of the rubber plunger head. With a smaller internal volume, the now excess fluid is forced to flow to the patient, resulting in a period of increased delivery. This increased delivery is temporary, though. Eventually, the tubing, syringe barrel, and plunger stabilize at their new diameter and thickness. There is no longer any excess fluid in the setup, and the flow once again is solely driven by the pump. Extrapolating from what was just discussed, what do you suppose can happen when the pump is suddenly at a position below the patient's heart? Gravity is pulling the fluid downwards towards the pump, dissuading its flow to the patient. As a result, what do you suppose happens to each of the compliant components of the IV setup? Before we discuss the answer to this question on the next slide, try answering this question yourself using the button shown next to each component. The pushing mechanism of the syringe pump moves at a constant rate, so fluid may continue to flow out of the syringe, but gravity is restricting the flow, and fluid is building in the tubing. This is a little bit like what happens during a soft occlusion, and similarly, the pressure in the component setup is increasing. While it is usually not enough to trigger an occlusion alarm, this pressure is expanding the compliant tubing and syringe barrel and compressing the syringe plunger. This serves to increase the internal volume of the setup to accommodate the fluid, which is no longer flowing to the patient. Therefore, when the pump is suddenly at a position below the patient, there is decreased delivery or even no delivery. However, since this is a bit like a soft occlusion, pressure only builds a little bit, and the syringe and tubing will only deform so much with this pressure. Eventually, they stop expanding or compressing, and fluid will resume flowing to the patient, meaning the resulting decrease in flow is temporary. In summary, when we move the pump up or the patient down, the result is a temporary increase in delivery. When the pump is moved down or the patient up, there is a temporary decrease in delivery. Let's look at a situation where the pump's height changed multiple times over the course of an infusion and its impact on the delivery rate. In this example graph, an infusion was programmed to run at about 1 milliliter per hour. At point A, we have a temporary increase in delivery brought about by the pump being moved 2 feet upwards. At point B, we have another smaller temporary increase in delivery brought about by the pump being moved another 1/2 foot upwards. We have a sudden, prominent decrease in delivery at point C, where practically no flow occurs. This was caused when the pump was moved downwards, back to being level with the patient's heart. Finally, at point D, we have another drop in delivery caused when the pump was moved a foot further down below the patient's heart. There is something else that can further exacerbate the temporary increase in delivery when the pump is suddenly at a height above the patient's heart. Remember in the previous module, discussing how the syringe fits within the pump's capture arms and the implications of there being a sizable gap during startup? During startup, the gap is above the plunger button, and removal of slack closes this gap. However, once running, this gap is now below the plunger button, and this type of gap can lead to a different type of issue. As mentioned, With a significant rise in height, there is an increased gravitational pull on the fluid. If a gap is present and the pump is suddenly much higher than the patient, this pull, as fluid quickly tries to flow to the patient, may be sufficient to draw fluid right out of the syringe. Normally, this is prevented from happening by the capture arms not allowing for the free movement of the syringe plunger button. However, with poor fitting capture arms, there is nothing preventing the plunger button's movement, and additional fluid can be siphoned out of the syringe and delivered to the patient. 60 milliliter syringes are more susceptible to this type of gravity siphoning if a gap is present. Even though the frictional forces within the syringe barrel may be similar in 60 milliliter and a smaller 20 milliliter syringe, the cross-sectional areas of the plunger heads are significantly different. The larger the cross-sectional area, the easier it is for gravity to instigate movement of the plunger. Therefore, smaller syringes will be more protected from unintentional siphoning. The issue of gravity siphoning with ill-fitting capture arms can even be an issue when the pump is not running and no height change occurred. If the resting height of your pump is at a sufficient height above the patient and not running, you may have manually paused the flow or are in the setup process. The gravitational pull on the fluid may be enough to overcome the friction preventing the plunger from moving. If the capture arms are not tightly restraining the plunger's movement, fluid can start to flow from the syringe to the patient. 60 milliliter syringes are particularly susceptible to this. To mitigate the possibility of unintentional gravity siphoning, regardless if the pump is running or not, you should make sure your institution uses syringes whose plunger buttons fit well within the capture arms of the pump with a minimal gap. Furthermore, if clinically reasonable, try to use a syringe smaller than 60 milliliters. Also, for rate-critical medications, consider organizing these pumps such that they are the pumps closest to being level with the patient to protect from gravity siphoning when the pump is not running. In summary, with regards to changes in the relative height of the pump, keep the following guidelines and recommendations in mind. Another element related to compliance and having the potential to influence most of the topics we have discussed is the presence of air within the syringe. We are not talking about air bubbles traveling to the patient, but rather air bubbles simply being within the syringe. Some gases and fluids change volume when they experience a force such as pressure. Gases, such as air, will change their volume much more than fluids. At high pressures, air will compress in volume more than fluids, and at low pressures, air will expand in volume more than fluids. When something causes a change in pressure, the effect on the setup will be greater when air is present in the syringe. Throughout these modules, we have covered many instances resulting in pressure changes, and we can expect the following heightened considerations when air is present. As such, we should always try to ensure there is no air within the syringe. This is also important since there is no mechanism in syringe pumps to detect air in the line. While the mechanical design of syringe pumps have some inherent limitations which can affect medication delivery, the selection of your disposables, such as syringes and tubing sets, plays an equally important role in minimizing variations in delivery. You may have a choice in the disposables you use, or you may be limited to a few choices, such as having only a defined set of pre-filled syringes provided to you by the pharmacy. This section aims to provide some guidance to help direct your selection and some recommendations worth raising with the pharmacy and your institution. Over the course of this module and the previous one, we have frequently highlighted the benefits of using smaller sizes of syringes where clinically possible. These benefits have included shorter startup delays due to slack, better flow continuity, smaller variations due to stiction, faster occlusion detection, and the narrow diameter means expansion and contraction due to compliance is smaller, so there will be less of an impact from height changes and unintended post-occlusion boluses. With these benefits, it is easy to see why selecting the smallest syringe size that is practical for your specific clinical purpose can be clinically beneficial. However, Selecting the smallest syringe size is not always an easy task. Smaller syringes do have all the previously listed benefits, but due to their smaller volume, it also means that you may have to change the syringe more frequently. A frequent changeover also means enhanced concerns of contamination. Therefore, when you have the option to select between multiple sizes of syringes, you will have to balance the benefits and trade-offs, and select a syringe size according to the specific clinical situation you are dealing with. If you have a patient where any deviations or irregularities in flow will have significant physiological concerns, or it is a slow flow rate, you may lean more to selecting a smaller size syringe. Contrastingly, if a patient is receiving medication where irregularities in flow are unlikely to produce significant physiological concerns, or being delivered at a faster flow rate, you may stay away from selecting too small of a syringe. This selection would mean you do not have to change the syringe as frequently, and thus minimize opportunities for contamination during changeover. The selection of your IV tubing should also be a key consideration. One important element to IV tubing is its internal diameter. The smaller the IV tubing diameter, the smaller the effects of tubing compliance. As a result, there are benefits of using narrow diameter tubing, such as faster occlusion detection, smaller post-occlusion bolus size, and smaller flow deviations following height changes. Also, to a certain extent, smaller diameter tubing can mitigate increased flow due to a sudden height change, as it offers greater resistance to uncontrolled flow due to gravity. Albeit, the tubing influence on these benefits is small when compared to the syringe's influence. Narrow diameter tubing has another benefit though. Narrow diameter, or microbore tubing, has a small priming volume. When compared to bigger diameter tubing sets, less volume will remain lost in the tubing following the infusion. This is referred to as dead volume, dead space, or shared infusion volume. Less dead volume is especially important when delivering small volumes, as it means a greater proportion of the medication is administered to the patient. We will talk more about dead volume and its implications in another module. Despite its benefits, small diameter tubing has a trade-off. Small diameter tubing may not permit flow at high flow rates or drug bolus rates, and the flow of viscous fluids. In these situations, even without an occlusion, pressure may build easily, predisposing the system to more occlusion alarms. To ensure you select tubing that will permit flow at the rates you will require, it is important that your institution test your tubing sets and provide information on the flow rate restrictions of the tubing. When selecting tubing, you may consider adopting IV tubing sets that incorporate an inline stopcock or vent close to the proximal end of the tubing, where it connects to the syringe. The previous module discussed the value of this type of tubing for removing slack during startup. It can also assist in venting the excess post-occlusion bolus fluid from the IV setup. For patients receiving medication where startup delays and post-occlusion boluses would be a critical concern, this type of tubing may be a valuable resource. In summary, with regards to the selection of your syringes and IV tubing sets, consider the following when using syringe pumps. As we approach the end of this module, let's return to the 3 case studies introduced at the start of the previous module. Knowing what you know now, can you determine what caused the unintended outcomes in these cases? The next slides will recap what occurred in each case and allow you to try and answer what led to each situation. The next couple of slides include some optional practice questions on the material presented in both modules of this series. If you would like to skip these questions, you can click on the Skip to End button. Pressing the next button will go to additional questions. Syringe infusion pumps have and will continue to play an essential role in helping us provide quality care to neonate, pediatric, and adult patients. However, as these modules have highlighted, The way the pump operates in combination with the properties of the syringe and tubing can have an impact on clinical performance. Being aware of these aspects of syringe pumps and understanding why they occur is important to ensuring we use them in a way that promotes the best outcomes for our patients. Here are some of the key messages to carry forward as you continue to use syringe pumps. The topics covered in this module and the previous one primarily focused on the way syringe pumps physically operate and how this operation can be influenced by how we use them. Upcoming modules in this series will focus more on clinical practices that can help us optimize the use of syringe pumps, and to a certain extent, all infusions. These topics will include the use of carrier fluids, accounting for dead volume, and drug mixture and preparation considerations.